Hi, good morning, everyone. Still waiting for people to join us. I'll give another 30 seconds or so before we start the seminar. I mean, it's been great. We've had roughly about over 200 people booked for this seminar, so I think it shows the real importance and interest in the experiences of Black and racialized communities around aging better in later life. Okay, I think we should start now, everyone. So good morning and welcome to this very first seminar from the Centre of Aging Better, where we are looking at ethnic health inequalities in later life. I'm Patrick Vernon. I've been at the Centre for Aging Better for about 2.5 years. I'm an Associate Director in terms of the work that we've been doing around connected communities, which is part of a strand of work that we're doing and integrating around people aging in later life. We've got fantastic speakers this morning, Dr. Sarah Stopford from the University of Sussex and Dr. Habib Nabi from the NHS Race Observatory. So before we start, some basic housekeeping rules. We are streaming this session live on the Aging Better YouTube channel, and the webinar will be available on demand once this seminar finishes at 12. All live attendees, you're all just in listening mode. And if you have any questions for the panel, if you can use the Q&A chat box, please, which is the control button, the control ribbon at the top or bottom of your screen. Also, please welcome to use the chat to share information or links or any comments at all. We do have a closed caption, which is available to all. And this can be turned on and off by pressing the CC button in the control ribbon on your screen. So, today's seminar will explore the research work from a number of academics from University of Sussex and Manchester, which was published in November. Actually, we'll put the link in now on the chat. And I have to acknowledge within the Centre for Aging Better, Dr. Aideen Young, who's our evidence manager, who played a supporting role. Unfortunately, she's not well today, so she can't join us as part of our Q&A panel. But Aideen, hope you get well. So what do we know? I think the report that we're going to explore, for some of you, it may not be new to you, but what's more important is at the Centre for Aging Better, along working with Sussex and Manchester University, we recognise more work needs to be done around exploring the stark inequalities affecting a range of Black and minoritized communities, particularly around their health status as they age. We know in terms of demographics that racialized communities are a younger population, but at the same time, we are getting older. And just from my own experiences of even my own age, for those people who are first, second generation from Windrush generation, we are getting older. So what's important in this research work is the glaring inequalities if we compare the lived experiences compared to white peers. We know there is issues around data. We also know that in the context of COVID-19, that has further exacerbated and the whole issue around the vaccine uptake, that has further intensified health inequalities and also racial inequalities as well. This report, which the Centre for Aging Better has been happy to work with and be part of, has explored this in later life, and particularly around the age cohort. We look at the ages between 50 to 70 in terms of all our work, but we also recognise that particularly for those racialised communities, often it might be your health status at an earlier age, which has an impact on how you progress later in life as well. We recognise about the socio-economic factors. We know about the impact of racism, structural racism, which may have an impact on people's health status, and issues around self-reporting of people's health as well. These are big issues. Unfortunately, we have a limited time. We can't explore everything, but the report itself, I hope, will be a call for more research work, more evidence, and particularly in the changing NHS landscape and care landscape, that we can have better quality services. So I'd like to invite Sarah Stopford from Sussex University, who's one of the key lead researchers on this project, and she will kind of give an overview in the next 10 minutes regarding the key findings of this research. Over to you, Sarah.
Thank you very much. And can I just check that you can see my slides now, that they've updated?
Yes, we can see you and we can see your slides.
Excellent. Okay, I will crack on then. Thanks very much, Patrick. So my name is Sarah Stopforth. I'm a research fellow at the University of Sussex. And today I'll be presenting the findings from a project I'm working on with colleagues at the Universities of Manchester and Sussex, looking at ethnic health inequalities in later life. Move on, there we go. So that should have moved, so let me know if it hasn't. So the talk will draw upon this briefing in the centre with colleagues at the Centre for Ageing Better, which you may already have seen, but I've seen the link has gone into the chat, so that's good. And this briefing brought together two separate but interrelated pieces of research that we've been working on as part of this project. And so I want to go through these in a little bit more detail in this talk. So if I just briefly set the background and the context to the project kind of more generally, we know that ethnic inequalities in health and well-being are really quite well documented across the earlier and the midlife course. So we know, for example, that people from minoritized ethnic groups tend to have worse health outcomes than people from the ethnic majority, or in the UK, the white British group. So explanations for these ethnic health inequalities are quite complex, and often we see that socioeconomic inequalities are used to explain the health inequalities. And there's an intrinsic link there between ethnic inequalities and socioeconomic inequalities. Often the underlying cause of socioeconomic inequalities are not made as explicit. So for example, the role of racism and racial discrimination. So at the outset of the project, we knew that ethnic inequalities exist in the earlier and midlife course, but we didn't know as much about what happens in later life. So the project itself is using existing data resources to address this really key data and evidence gap. So if I move to the first piece of research that we've done, this is where we analyse census data from the 1991, the 2001 and the 2011 census for England and Wales. And we found that ethnic inequalities in self-rated health, so this is a question which you may remember from the 2021 census that has just gone, is a question on general health, and respondents are asked to rate how they feel their general health is from very good to very bad. And what we found is that ethnic inequalities in this measure of self-rated health widen after the age of 30, with many people from minoritized ethnic groups exhibiting much poorer health outcomes than the white British group. We also found that these inequalities persist over time. So we compared it to the same outcome in the 2001 census. So we see that it persists over time, and we also see that it tends to be particularly pronounced for women more than men. So to illustrate this with these graphs are plotting the percentage of men and women by age and ethnicity who reported poor health in the 2011 census. So for the purposes of these graphs, we've aggregated the bad and very bad responses to how do you rate your general health. And we can see from these graphs, I wonder if you can see my cursor. I don't know if you will be able to, but from you can. Good. From these graphs, you can see up until the age bracket of 30 to 39, there are very little differences in the percentage of people reporting poorer health by ethnicity. From the age of the 30 to 39 age bracket onwards, though, we see this really clear divergence in inequalities in health and a widening of inequalities over the mid and later life course. So if I highlight some of the points here, we can also start to look at the magnitude of these inequalities. So the points that I've circled in this turquoisey colour represent the rates of poor health for white British people in their 80s, so in the 80 to 89 age bracket. And we can see that the poor health rate of white British women in their 80s, so if you look at the left-hand graph, is equivalent to or lower than the rates of poor health for Black, Caribbean and Indian women in their 70s, so it's these 2 points here, so women 10 years younger. And these rates for white British women in their 80s are also equivalent to or lower than the rates of poor health for Pakistani and Bangladeshi women in their 50s, so it's 30 years younger. We see a similar pattern for men, where the poor health rates for white British men in their 80s is equivalent to the poor health rates of Black Caribbean men in their 70s, Pakistani men in their 60s, and Bangladeshi men in their 50s. So we can see these really stark inequalities from this census data. So in the next stage of the project, and kind of an interrelated piece of work that we've done, we look to investigate this further. One thing to note is that there's no single source to study ethnic inequalities in later life over time. And there are quite serious data gaps in terms of sample sizes of older people, particularly. So we searched for a range of suitable data resources, and what we've done is harmonize different data sources so that we can have a look at what happens over time. And we used the 4th National Survey of Ethnic Minorities from 1993, the Health Survey for England in 1999 and 2004, the Citizenship Survey in 2007, and then 2 waves of Understanding Society, which is the UK Household Longitudinal Study from 2009 and 2015. So what we have are 6 data sets which span more than 20 years, and we're using the same analytical sample in each, which is those aged over 40 and living in England. So the reason we use people aged over 40 is because we know from previous work that we've done, and that I've just shown you there, is that ethnic inequalities begin to open up during the 30 to 39 age bracket, and inequalities are quite well established by the age of 40. We also know that there's evidence of earlier onset of ill health for people from minoritized ethnic groups, so that's why we've kind of started from 40. So in order to examine the existence and the persistence of ethnic inequalities over time, we harmonize these data sets, and we estimate the same cross-sectional statistical models. We're applying the same model, but separately to each survey to see what happens over time. And what we find is that ethnic inequalities exist in health for those aged over 40, and that these trends are observed in all of the survey years that we look at. So we also find that age is significant, as we might expect, and we also see that women tend to have worse health than men, which is also consistent with previous work. When we additionally adjust our models for socioeconomic position and racism and discrimination, we find that they have associations with poorer health, which is also consistent with previous work, and that they are partially explaining the reason why we're seeing the health inequalities that we do. So if I show you another graph, this graph here is plotting the changes in probabilities of fair or poor health compared with the white British group. So I will explain, because these are there's quite a lot of graphs here. So we plotted them separately by survey year. The dotted line at 0, there we go. Dotted line at 0 is representing the white British group. So essentially we've kind of set the white British group at 0, and it means that any point above the line at 0 means that these groups have higher probabilities of poorer health than the white British group, and any point that's below the line at 0 means that these groups have lower probabilities of poorer health, so better health than the white British group. The error bars that you can see where these cross the line at 0, this means the results are not significant, there's not statistically significant differences, but if there's a clear gap between the error bar and the line at 0, then we have statistically significant differences in health. So overall, we can see there's a clear patterning of results in all survey years. So there's a very similar kind of trend happening over the course of the 20 years. And in particular, we see that the Pakistani and Bangladeshi respondents in these surveys have consistently worse health than the white British group, as do people from the Caribbean and Indian respondents in most survey years. After adding in, the graph gets a little bit more complicated, but after we add in model 2, so this is where we start to adjust for socioeconomic position, we can start to see that the inequalities are reduced. So the points are starting to come closer to this line at 0. They're not completely there, but they're starting to reduce. This happens slightly for most groups, and then quite substantially for the Pakistani and Bangladeshi groups. And then again, when we add in model 3, which is where we add in our racism measures, there's changes in probability, lower probability between the white British group and the other groups. So what we start to see from this is that ethnic inequalities in health persist over time. We've seen it across survey years, so 20 years of survey data from 1991 to 2011, and we've also seen it separately across 20 years of, I think I said survey data, I meant census data, and then 20 years of survey data as well. We are seeing that many ethnic minority groups are exhibiting poorer health outcomes and quite significantly so than the white British group. And particularly we see that Pakistani and Bangladeshi people tend to have the worst health outcomes overall. We see that these inequalities are partially explained by socioeconomic position and measures of racism and discrimination. And then we also see similar patterns, which I haven't shown here. I've shown just the self-rated health outcomes here, but we also kind of replicated the analysis with a different measure of health limiting long-term illness, and we're seeing very similar trends, very similar patterns throughout. So that's kind of, I think these slides will get shared afterwards, so you can have a look. These are the outputs from that. I think the main one for here is the Centre for Aging Better briefing paper will be is in there as well. And I just wanted to acknowledge the other members of the project team here, Dr. Laia Figueres, Dr. Demokpadia, and Professor James Nasri. And that's me. Thank you.
Thanks very much, Sarah. And again, please, if you have any questions for Sarah, can you please put them in the Q&A at all, and you'll have opportunity to explore that. And I'd like to invite Dr. Naveed from the NHS Race Observatory. I've known Naveed for a number of years. He's was part of that key team working with Yvonne Coghill around establishing the Workforce Race Equality Scheme. And I'm really glad that he's got this fantastic job and this opportunity at the Race Observatory to really shine light on ethnic health and equality. So over to you, Habib.
Great. Thank you so much, Patrick, and thank you for inviting me to this really important seminar. And thank you also to Sarah for that excellent presentation. So firstly, congratulations, I think, to the Centre for Aging Better for this excellent report. And congratulations to Sarah and the team, including, I have to say, Professor James Nasri, who's a board member at the NHS Race and Health Observatory. I'd just like to put into context, I guess, the approach around looking at identifying and tackling ethnic and racial health inequalities and how it aligns with the findings of the report and some of the conclusions highlighted by Sarah. What we know, I guess, to begin with, is that if we step outside of the health kind of area, that racial and ethnic inequalities in general are global and they're widespread, and they require a global response. When we look at health specifically, we know that there is a level of, I guess, stratification by ethnic group in terms of access, experience, and outcomes across a range of different areas, including genetic counseling, artificial intelligence, maternal health. And of course, we also know that these disparities are set against higher prevalence of specific diseases and conditions. And we know all too well the specific types of conditions and diseases, specific cancers, cardiovascular disease, diabetes, mental illness, and as we've seen, I guess, over the last 2 years, the disproportionate impact of a pandemic, COVID-19, on our ethnic minority communities, including, of course, critically, ethnic minority health and care staff as well. I guess our country and our healthcare system should be well equipped and ready to respond to the immediate challenges that we have around ethnic health inequalities. We've always had a long history of migration in this country, and therefore have large and growing ethnic minority communities. And as Patrick said earlier on, those communities are now aging. We have a robust legal framework in the Equality Act and the Health Inequalities duties. We've always had very good investment in healthcare research, and the vaccine, the COVID vaccine, is just one example of perhaps a very long list of cutting-edge medical research and interventions in this country. However, it can also be said at the same time that our responses, our country's responses, and our healthcare system's responses historically have been somewhat fragmented, costly, and confused. And whereas specific organizations and units have been set up to focus on racism, and racial health inequalities, they have, it can be argued, in the main, focused on looking at kind of theoretical recommendations and academic kind of exercises around data collection without looking at implementing those recommendations on the ground with regards to policy change. It was just before the pandemic that a very strong argument was put in the British Medical Journal, the BMJ, for the establishment of the NHS Race and Health Observatory, a special edition that was published in February 2020 entitled Racism in Medicine, that at the launch, the chief exec at the time, Sir Simon Stevens, put his hands in his pocket and said, yes, actually, this is a good thing to do, to hold up a mirror to our healthcare system with regards to the challenges that we have around ethnic health inequalities. And the observatory was established, and of course, I think it was a month later we had the onset of COVID-19, which again highlights the importance of having objective viewpoints, the data, the evidence, the policy recommendations to impact upon some of the challenges that we've seen, particularly over the last 2 years. There are stark inequalities, as I mentioned, and as the report rightly highlights, these inequalities have persisted unchanged for decades in this country. And whilst the ONS latest statistics around life expectancy, I think, which were launched just a couple of months ago or so, highlighted from that particular perspective higher life expectancy now for some of our ethnic minority communities compared to previously, we also need to keep in mind a number of points. Firstly, that of course those were experimental statistics, and we need to look at the kind of the robust methodology behind some of those statistics and test those out in a more robust way. But also the point that actually, if that is true, then we also need to keep in mind that actually living longer does not always mean living in a healthy way. And we need to look at, as I mentioned before, some of the disproportionate impact that we have on our ethnic minority, that diseases have on our ethnic minority communities. Of course, you know, diabetes, hypertension, etc. Some of the kind of limiting conditions and diseases that will persist with individuals as they live longer lives. And of course, what we need to focus on is not just the surface level issues with regards to these conditions and these challenges, but to focus on what we often refer to as the causes of the causes of these challenges and these issues. And of course, as Sarah's highlighted, even when accounting for differences in socioeconomic position, poor health with regards to access and experience and outcomes is still common among certain ethnic groups. And the data is very clear, as highlighted by Sarah. The Bangladeshi groups, the Pakistani groups, the Black Caribbean groups, and some of the other ethnic minority groups fare worse with regards to experience and outcomes compared to the white British communities. And therefore, when we begin to think about the what is it that we want to do, not just across the healthcare sector, but particularly from our perspective within the NHS Race and Health Observatory, we know that we need to focus on, within the observatory, on three things, which is kind of the key cornerstone of the way that we operate within the observatory. Firstly, to bring together the evidence base and the research around ethnic health inequalities. Where it does exist, that's great. Where it doesn't exist, we need to look at bringing that together in a kind of rapid way. Secondly, to turn that evidence into actionable recommendations for policy change on the ground, and that's very critical here. And then thirdly, to support the healthcare system and other institutions and bodies to implement those policies on the ground. Now, to do that, we need to make sure that the work that we do is evidence-based, is informed by stakeholder engagement. Now, engagement with our communities and patients and with the healthcare system, which is not tokenistic, but which is both meaningful and sustained over time. That is absolutely critical in the work that we do. And that work is based upon kind of a work program that we brought together just over a year ago now through engagement. A work program, as you can imagine, when we set out on that task, was a very long list of things to do for us. And we kind of finalized a program that would enable us to do a number of things. Firstly, to focus on some of the deep-seated health inequalities that we have across our society, including a focus on maternal health, but also on mental health issues. To be responsive to the emerging issues of the day, and we've been doing a lot of work around COVID-19, for example, very early on with regards to engagement with our communities, with regards to the vaccine, with health and social care staff from ethnic minority groups, and now looking at some of the backlog in elective care and routine appointments that are built up over time as a result of the pandemic and what that means for us, and particularly our aging populations with regards to missed appointments around diabetes or missed appointments around hypertension clinics. And whether or not that will eventually be a kind of ticking time bomb for public health issues going forward. But also, our work program enables us to keep this agenda high at the forefront of leaders' minds and to focus on, as I mentioned, the evidence base and the critical engagement that we need. So some of the things that we have been focused on over the recent period, I'd just like to highlight, and a work program, as I mentioned, that covers a lifespan from neonatal health to end-of-life care, and of course at critical periods in between those two milestones. We've recently commissioned what will be the first ever review of the APGAR score and neonatal and postnatal checks. The APGAR score, just to put it into context, is a score that's now been around this year, will be the 70th year since it's been around since 1952, but includes a level of racial bias within it. I mean, checking whether or not a baby is healthy based upon the color of its skin, whether it's pink or not, may have been kind of more true in 1952, but certainly isn't in 2022. We've also commissioned what will be the first ever independent review of the IAPT program in mental health, the access to psychological therapies, which it cannot be right, for example, that today in 2022, Black and African Caribbean people are up to 8 times more likely to be subjected to community treatment orders compared to their white counterparts. Focusing on IAPT, focusing on making sure that IAPT is inclusive to all of our communities is something that will be absolutely critical as we move forward to look at some of the wider issues around mental health. And that is one of the things that we are focused on. I mentioned COVID-19 already. I probably do not want to mention too much around that, but COVID-19 has shone yet another bright light on the ethnic health inequalities that we have in society. And we are doing a lot of work around COVID-19 as well, including, of course, looking at long COVID and the impact of long COVID amongst our ethnic minority health and social care staff as a proxy of looking at long COVID amongst the wider ethnic minority communities as well. As we move forward with time, we know that there will be more and more cutting edge health technologies and medical interventions. Genomics, genetic testing is something that we are interested in looking at within the Observatory. Looking at, for example, access to genetic testing for various conditions, looking at the applicability of certain genetic tests for ethnic minority communities as well. And we will be kicking off a piece of work in the coming months around that specific area. But we also know that digital health is something that will be a thing of the future, as it is becoming widely so, particularly during the pandemic. And I think to my 74-year-old Pakistani mother, whose first language is not English, who does not have access to digital technology, does not own a mobile phone, would not know how to operate a laptop, for example, or an iPad. And yet, if she is to have digital conversations about her health with her GP, what would that look like? And of course, if you generalize that to the aging populations, as Patrick said earlier on, then we need to think about what does that mean for our diverse communities. And our approach, of course, should be to reduce rather than increase health inequality. So we need to make sure that our digital apps, for example, the NHS app, the COVID-19 app, the blood and transplant apps and other apps are accessible to our wider diverse and aging communities. And therefore, we have initiated an independent review of digital apps, those 3 in particular within the NHS. I guess I'd just like to finish and hand back over to Patrick. And before I do that, I'd just like to highlight some of the things that I think are key and critical for us as we move forward. Some of the things that in fact have been mentioned in the published Centre for Aging Better published report and the recommendations. Firstly, we absolutely agree with the recommendation around better data recording, better ethnicity data recording within the healthcare system and beyond is absolutely critical to what we do, not least because we know that what doesn't get measured, particularly in the NHS, doesn't get done. But it's not just kind of superficial higher level data, but data that is really meaningful. And to get to that stage, we need to move away from higher level umbrella terminology for ethnic minority communities and to have specificity by default. We published in November of last year a report looking at terminology use, making sure that actually the terms and the narrative that we use within the Race and Health Observatory is aligned and that to what people want to be used for them, and that they feel comfortable with that. And that report is published. It's on the NHS Race and Health Observatory website. And we are working at the moment with the NHS and various other arm's length bodies within the healthcare system to ensure that they can take those recommendations that we have forward with regards to ethnicity data recording and the quality of that within the system wider. And then finally, I also agree with the report's recommendation around a national strategy around ethnic health inequalities and the disparities that we see within society. We know the NHS is perhaps the most visible expression of a shared social contract between people, and we've seen that so vividly over the last 2 years with regards to the pandemic. But we also know that to be proud of our excellent healthcare system and the NHS is not to be blind to some of its imperfections, and the stratification that I've highlighted in some of the access, experience and outcomes that we see in some of the diseases for our ethnic minority communities are some of the imperfections that we have within the healthcare system, which we want to work in collaboration with others to help and resolve as we move forward. On that note, Patrick, I'll hand back to yourself.
Thanks very much, Habib, for giving your analysis and the work of the Health Observatory, which I'm sure the Centre for Aging Better will be happy to work and support the work that you're doing. Sarah, can you just join us, please? We're going to now have a panel discussion. We've got less than 25 minutes or so. And we've got quite a few questions in the chat, but also we've had a number of questions that were sent to us in advance, and which I'll prioritize those first. But I've got a question first for both of you. I think you've highlighted in the report and your commentary about data. I mean, I remember going back to 2003, I was in the Department of Health. I was part of the Health Inequalities unit, and we put together the very first government strategy called Programme Together, Tackling Health Inequalities. And we were talking about data then, and now we're still talking about data. Why is it that we've not addressed this data gap? I mean, the work that we've done and a number of academics have done, and you've obviously the Race Observatory and other researchers have highlighted every single report you could think of for the last 20 years always says we need better data. But why is it that we're not doing this? I'll start with Sarah, and then Habib, can you please come in?
Yeah, I think it's something I can't answer. I don't know why it's not being done, but I just I know that it can be quite it's just like you said, it's just something that's been said so many times, and so many reports come out and say we need more data, we need more research on this, and it's just difficult to do with the data that's out there, specifically I think for older people, specifically for old people from minoritized groups. I'm sorry, I don't have an answer to why.
Okay, that's fine. What about you, Habib? You've been around the block like me. What's your
take? I think I was at the department probably 10 years after you, and also working on the data. So I think some of the long-standing challenges historically here are around the kind of the fragmentation in terms of different systems not speaking with each other across the healthcare system, and also the inconsistencies that we have in some of the codings that across the system as well. So some organizations still using the 2001 census categories, some using the 2011 categories. We're now heading into the new categories that will be launched as well from the census. So there needs to be a level of consistency, and in order to do that, as we highlight in our report that we published last year, some work we did on this in collaboration with the Nuffield Trust. There needs to be a serious conversation around this amongst the leaders across the healthcare system. And what we have been doing over the last couple of months or so is to have those roundtables with those policy leads within the organizations, and are currently working on a paper that we will be putting out to those organizations around what can be done practically on this. Because, the bottom line is that if we do not have robust, meaningful data and an evidence base, we will not be able to know where we are with some of these challenges, where we need to get to, and what we need to do, of course, in order to get to that endpoint. So, data and the evidence base is absolutely critical as we move forward.
Thanks, and just a supplementary question before I go straight into the questions that we've been sent already. So at the Centre for Aging Better, our focus is around people and aging, a cohort between 50 and 70, recognise that some inequalities or morbidity issues might happen at an earlier stage in people's life as part of that life course. We submitted evidence to the Centre for Race Disparity, Tony Sewell Commission, making a case about focus on ethnic health and racialized communities aging better in life. There's often a lot of focus on young people, and that's important. What is the best way to ensure that this report that we're doing and other reports that everyone's doing around people aging worse actually in life can be taken more seriously by policymakers, politicians and commissioners? Sarah, any?
Besides kind of presenting the data, I think it's quite it's something that keeps being found with all the different data resources at the earlier kind of onset of ill health, the earlier onset of the inequalities in health that happen at a much earlier stage, and we've shown it in this work from the age of 40. It's absolutely already kind of entrenched. So I guess thinking about things in a life course perspective is so important in this area. That's
Okay, fine. Habib?
Yeah, no, I totally agree with Sarah. I mean, our work program, like I highlighted, covers a life course kind of perspective. And, we need to, I think we go back to the evidence base as well, because we need to have action to match the scale of the challenge. And if we don't have the evidence base around the scale of the challenge, then it's very difficult to kind of to put forward robust arguments as to where our focus of attention should be. But what we are doing within the NHS Race and Health Observatory, based upon the evidence that we have, is focusing on all the way from neonatal care to kind of issues around end-of-life care and dementia, learning disabilities within that period, and kind of the life expectancy gaps that we have within between ethnic minority groups with regards to learning disabilities. And of course, we're also looking at some of the other long-standing issues that affect different ethnic groups differently in terms of not just age, but along other protected characteristics as well. Sickle cell disease is one which is absolutely critical, I think, for us to focus on, and we are beginning a piece of work, program of work on that. Looking at the patient pathway, looking at the holistic approach that we can have to some of these debilitating diseases and conditions. So I think the evidence base, the engagement that we need with communities in order to look at and focus on the issues that are at the heart of our diverse communities and their needs.
Okay, thanks for that. I just now want to share some of the questions that were sent in advance as part of the seminar. This is from Jean Bean from Fearless Aging. Her question is, PTSD, post-traumatic stress, starts to accumulate in the minds of ethnic minorities from an early age through racist abuses, unconscious bias, poor housing, and the differential pay gap. What can the panel suggest to identify and fix these problems? Can I come? I know, Abid, you've just signed a kind of declaration or MOU with an organisation in America looking at issues of research work around the impact of racism. Can you just comment on that and in response to this question?
So, firstly, I would say this is a very important question. We know of the links between racism and health outcomes, and there's a lot of work that's happening in that space, and particularly from the US. So we know of that particular link. Yes, I mean, the international point, Patrick, is absolutely critical as well, because within the NHS Race and Health Observatory, we're not just focusing on these challenges within our own geographical borders, but also looking at some of the common solutions and responses to some of the common challenges that we have around race, ethnic health inequalities, racial bias, etc. And we need to share good practice, replicable good practice, and we've brought together, for example, an excellent ethnic health inequalities expert group, which is international, with people working on these issues from New Zealand, Australia, South Africa, Guatemala, the US, Canada, and of course, Professor James Nasru from the UK. And that's exactly what we're doing, is looking at some of those common, what is it in New Zealand that they're doing around, looking at maternal health or looking at dementia with their Indigenous population that may be useful for us to take on board here with regards to our policy change. So that's absolutely right. And we are also working with, as you say, Patrick, with the Center for Disease Control and Prevention in the US, and have signed a memorandum of understanding with them to collaborate over the next couple of years with regard to some of these issues. And I think one of the first things that we will be looking at is kind of learning from the ongoing COVID-19 pandemic, and what is it that we can share and look at together in a collaborative way. Because as I said right from the outset, racial inequality is a global issue that requires a global response.
Yeah, I definitely agree to that. The next question, which I'll like put to Sarah, is claims are made about the widening availability of digital networks reducing inequalities. Do the speakers agree, and what needs to change? This is from Malcolm Fisk from De Montfort University.
What inequalities? Sorry, I'm widening of
widen availability of digital networks reducing inequalities.
Digital networks. I guess sorry, I don't think I'm best placed to answer that one, but could I just talk a little bit about what Habib has just said about the,
yeah, sure.
Sorry about that. Just it came to my mind that we know a lot about the socioeconomic inequalities kind of underpinning health inequalities, and the fact that the underlying cause, and Habib talked before about the causes of causes, which I think is such an important point, and underlying that is the structural disadvantage and the structural racism that leads to these socioeconomic inequalities. It's something that I think should be kind of more at the forefront of these discussions. I think it's a really important aspect of them. And again, in terms of there's a lot of international evidence on racism and health and the impacts and whatever, and just wanted to highlight that we're currently working on that for the UK as well. We're looking at the pathways of how racism affects mental and physical health as well.
Okay, you got anything to comment on the digital question, Habib?
Yeah, I think it's a point I made earlier.
Yeah.
The ethnic minority communities, as you said, Patrick, are aging, and we will get, and they will continue to, we're kind of heading that way now with the kind of the levels of migration that we've had over time. And therefore, looking at digital access to care, digital technologies, looking at kind of cutting edge medical interventions like genetic testing, etc., will come more and more to the forefront. And we need to make sure that actually, as I mentioned before, that these interventions help to reduce rather than to increase health inequalities. And that's something that we need to keep a focus on. And therefore, the recommendation in the published report around having that national conversation and having a national kind of strategy to focus on ethnic health inequality specifically is absolutely critical as we move forward. Otherwise, the risk is that these inequalities will persist and potentially widen over time as well. linked to that point, I guess, is the concept of trust as well. And I wanted to bring that up because, the issue of trust, I know, Patrick, you've done a lot of work with communities around trust amongst our ethnic minority communities. And, in the wider sense, I guess, trust with our healthcare system, trust with our statutory bodies, that is absolutely critical. And some of the things that we've seen over the last 2 years or so, particularly more recently with the COVID-19 vaccine, is the issue of certain ethnic minority groups not taking up the vaccine, and that level of, I guess, the lack of confidence or the mistrust, I guess, that some communities have. And that is historical, and it's not just focused, it's not just in relation to race, but is in relation to other aspects of kind of experience and key events over time, historically, that we need to focus on. And very fast, we are recognizing that the concept of trust itself perhaps is becoming a determinant of health as well. And so we need to kind of focus on that. So when we think about digital technologies, when we think about medical, cutting edge medical devices, we need to keep in mind the concept of building trust with our communities as we move forward.
No, absolutely. I trust that could be a whole separate seminar that we could explore on that. Next question is from Joseph Oj from UK HSA. What work is being done to influence governments not to decrease the age of prescription charges? I know for the Centre of Aging Better, we have an age-friendly communities network of, we've got 40 local authority areas signed up to that work. And within that, there are older people who are campaigners and who are raising issues around a whole range of stuff, not just around prescription, but also around issues around transportation, etc. So I don't know if any of you got comments on that around the prescription stuff. It might be something that we might want to look at ourselves anyway as an organisation. If not, then the final question that we received in advance is from Bridget Sam Bailey from the Lewisham Pensioners Forum. These inequalities do not exist only in ethnicity. They also exist in age and in gender. I can attest to all three of these. How can we ensure there is connectivity? If I want to add and build on that, say it's about intersectionality. Obviously through your research, Sarah, you've demonstrated that. Anything that you might want to add to that? And Habib, in terms of the work of the Race Observatory, how is the importance of intersectionality around ethnic status, health status? Sarah?
Yeah, I think this is a really important point. I think intersectionality is something that this kind of research really needs to take seriously and really needs to embed within it. So what we can see is that there are age differences in health, which I think are to be expected, and the women tend to have worse health than men. Unfortunately, for the data that we've been able to analyse, we haven't been able to kind of dig into that any deeper in terms of kind of formally looking at intersectionality, because you need a much greater sample size, and this is kind of a recurring problem with this kind of work, particularly as you get into the older age groups, and having enough people who have answered the surveys to actually start to look at this. But absolutely, it's the direction of travel, absolutely, to look at this.
Okay. Habib?
Yeah, it's an important question. I would say that every one of us has a minimum of 5 protected characteristics. People from ethnic backgrounds have an age, have a sex, etc. And the work that we're doing, as I said, kind of spans the not just a kind of the life course, but also when we focus on kind of neonatal health and the health of mothers, when we're focusing on various other kind of protected characteristics when it comes to disability, for example, when it comes to looking at the wider definition, the broader definition of race, and we're working with we will be working with the Gypsy, Roma and Traveller community. We are going to be kicking off some work with the Jewish community as well. It's about looking at what does this what would benefit our communities, our diverse communities in the broadest sense, but also as part of that, looking at what is working well for our ethnic minority communities and how that can be shared for the majority. It needs to be kind of both ways, but we do know that we need to, as the phrase is, kind of to level up. We need to look at reducing the gaps that we see, and which the Centre for Aging Better report clearly highlights, disproportionately impact upon certain ethnic minority groups as well.
Thanks. We've got time for a couple of questions that have been submitted in the Q&A function. So first question is from Nusrat Ali. Hi there, Nusrat. Nusrat's one of our trustees at the Centre for Aging Better. Happy New Year to you. So this is a question for you, Sarah. Thank you, Sarah. Clear presentation from the research and conclusions. What are the recommended solutions to shift and change the trajectory that you've gone through?
I think this is, thank you for the question. I think it is about building the evidence-based, galvanizing the evidence-based and taking it seriously and moving forward with it. I think it's about taking a life course approach to people. And we only see people in surveys at one point in time, but what has happened before then, and if we can collect kind of information on what's happened and how it's understanding how these things have happened, how I think inequalities kind of really magnify after the age of 40, and getting into that. In terms of, again, a data point, I think we need better quality data, particularly survey data, to understand this and understand kind of life course experiences of socioeconomic position and racism, discrimination, to really understand what's happening in the present.
Thank you. And another follow-up question for you, Sarah. This is from Ross King. The question is, again, thanks for the fascinating talk. I was wondering whether there is any data available that might be able to break down whether differences in self-reported poor health and related to physical versus mental health outcomes. Is it possible that the data you use, are there other public data sets that you can use to granulate these much further?
Yeah, I'm sure there is, to kind of approach it in a different way. Yeah, it's an interesting point, because the way we've approached it is to try and get the same analysis across all the different surveys. But I guess by it's an interesting point. I'll think a bit more about that. It's definitely, it will be possible to relate the different data sets and have a look at different outcomes. Yeah, it's an interesting point. Thank you.
Yeah, and another question linked to data, again for you, Sarah. I don't want to get this all out of the way. And this question is from, or is it, trying to find it now? This is from Elaine Rushbrook. She comments that you didn't use the ELSA data. Is there a reason for that? And are you doing further investigation once the 21 census is released?
2021, yeah, absolutely. When that is released, then we'll continue to expand this analysis. There is a reason why we didn't use ELSA, and that's because the sample sizes of older ethnic minority people are really low. So I had a look at this. There's 500 people in the last waves, which, yeah, it's just not enough to kind of do the robust analysis that we would like to do.
Okay, great. There's loads of questions here. I'm not in a position to get back to all of them, but I just want to thank everyone. I agree that I think we've had a real rich, provoking conversation. This is our very first seminar for this year. We'll have others covering the whole aspects of aging as well. So again, I'd like to thank very much our speakers. Sarah Stopford from Sussex University, Abid Nabi from the Race Observatory. Again, thank you for everyone for listening and contributing in the chat as well as your questions. I'm sorry we couldn't answer all your questions in the Q&A, but that's how the nature of things are with the limited time that we have. We also would like to have some feedback from you regarding what you thought about the seminar. And there's a link in the feedback in the chat for you to do evaluation. That will help us for future planning. This webinar, along with others, is available on our Watch on Demand on our YouTube channel, and auto captions will be available in the recording. I just want to say thank you very much for everyone for participating in the event. Let's keep the conversation going and have a great day, everyone. Thank you very much.